This morning, we are very fortunate to welcome Dr. Raina Merchant for the ongoing edition of our virtual Zoom Grand Rounds. Dr. Merchant completed medical school as well as residency in emergency medicine at the University of Chicago before joining the University of Pennsylvania as a Robert Wood Johnson Clinical Scholar. Today, she is an associate professor of emergency medicine within the Perelman School of Medicine at the University of Pennsylvania, and also serves there as an associate vice president within Penn Medicine, as director for the Penn Medicine Center for Digital Health, as co-director of the Penn National Clinical Scholars Program, and a member of the editorial board for the Journal of the American Medical Association. Her research focuses primarily on the intersection between health and digital media. Please welcome Dr. Raina Merchant.
Thank you so much for that warm welcome. I am thrilled to be here. And thank you also to Eric Bressman for connecting with me many months ago. I apologize that I can't be there in person, but perhaps one day when we are at a different time, I would love to, and I'm also happy to connect with anyone virtually. I also want to start with just a thank you to all of you as frontline providers in New York. I am a frontline provider, but Philadelphia was impacted differently than New York, and so thank you so much to all of you for the hard work that you did during the midst of the pandemic and in the ongoing stages. So I'm going to share my screen, and then I have another screen open with the chat. So I hope that you will use the chat if you have questions throughout, and then I will also take some pauses. And then I will follow the chat so that I can also, my chat has gone away. Ah, there we go. So that I can see as I'm going through. So I'm going to be talking a little bit about mining digital footprints to improve health and healthcare, and specifically as this is relevant to the types of data and data sources that we all use. I start with sort of my current grants and funding, of which there are no conflicts for what I'm talking about today, but also just to highlight that this work, while new and emerging, I've been fortunate enough to receive funding from NIH and other foundations and institutions to support this. I want to start with an image that I really like from a JAMA article a few years ago. And here you'll see what they described as finding the missing link for big biomedical data. And you'll see that there are lots of data sources that you'll recognize as things that we would intuitively think of as being related to health. So understanding medications that people are taking, thinking about their allergies, their medication diaries, their chief complaint, their differential diagnosis. And then there are also some things at the bottom of the screen, and I hope you'll use the chat to put in a couple of other sort of data sources that you think are now emerging that might give us clues or more information about being able to predict health. So you can add some things into the chat, but you'll see that there are things on this list like Zillow, which we might not have thought of as being related to your health, your LinkedIn, your Facebook friends, your Twitter hashtags, your credit card purchases as being very indicative of indications about our health, your blogs or postings. And so here you'll see someone put in Apple Watch and Fitbit. It's a great example. But just all these things that are emerging that are starting to be more representative, and that we're trying to understand what their role is in telling us about our health and how we use healthcare. So my colleagues, David Ash and Dan Rader, who are both internists at University of Pennsylvania, we, a few years ago, decided to call this area of study social mediomics. So, and that we wanted to study the social mediome. So we know we have a microbiome, a metabolome, all sorts of ohms. So we needed another ohm that would describe this area of study. And so here we've identified this as the study of the collective characterization and quantification of this social media data that might reflect structure, function, dynamics of an individual or a population. And I want to sort of first give it a couple examples that might be more relevant to our current era around sort of social media and coronavirus. And I want to acknowledge that we are at this confluence of sort of two catastrophic events, one being coronavirus and the second focusing on structural and institutional racism, and that it is that both of those events where we find ourselves today. While I'm going to focus on COVID, I wanted to just acknowledge that we have these sort of dual pandemics which are happening, and I'm going to talk about how social media has played a role in our understanding of coronavirus. And you can add some things into the chat if there are other examples. I think the thing that we most commonly think about with social media is around misinformation. So the WHO very early on sort of described that we were in the midst of an infodemic. There was so much information that people were having a hard time sort of trying to understand where to find accurate information. And there was just such a deluge of data that it's been a bit overwhelming. We know as physicians that people have used social media for sharing information early on about treatment in COVID, around different techniques that people were doing, around ways of maintaining social distancing. There's also a lot of other information out there which I would categorize as misinformation. And so it's sort of this double-edged sword with social media that you both have this incredible ability to connect, but also what comes with that connection is just an overwhelming amount of both information that is accurate and inaccurate. So my colleague who is also an internist, Dr. Nicole Lurie, and I wrote a piece very early on in the pandemic about sort of just the ways that social media could be used in response to coronavirus. And this was an update to a paper we had done in New England Journal of Medicine a decade before that talked about the use of social media and emergency preparedness. And so this, you may remember, was reported in The Economist early on about how you could use the latitude and longitude of the photos that people were taking on Instagram to then follow basically where people had been and then where they went after being in particular areas of high exposure. And so you could track and identify sort of spread potentially of disease just based on looking at the tags from photos that allow you to see how people are moving and the interactions that they're having. Another example, here our team has developed this Twitter map that's specifically focused on COVID, and you can find this online. It's updated every 24 hours, where we looked at differences in the types of conversations that people were having on Twitter relative to their mental health, relative to social isolation, loneliness, and then how the topics that people were talking about varied by state. There was this focus on panic buying very early on, economic concerns, and then we also were able to track symptoms on Twitter. So here we could see emergence of symptoms early before they made it to the list of COVID symptoms on CDC, because people were talking about them on Twitter well before they became a definitive symptom that was identified. So a lot of this was early on. We noticed a lot of conversation around dermatologic symptoms that hadn't yet made it to the CDC list. And then here you see how we track sort of engagement and sentiment on Twitter over time. Another sort of example that emerged was with the use of smart thermometers. So people purchased smart thermometers and then they were constantly taking their temperature. And then you could tell based on geographic areas where people were starting to have higher temperatures as being predictive of where there would be outbreaks. And so this was sort of a pretty blunt tool that was more of a sensor rather than social media, but sort of gets us the idea of sort of remote monitoring for symptoms that can emerge that can be used for tracking the course of a pandemic. And then there have been multiple examples in sort of New York Times and others of looking at data from mobile phones and seeing how that can be used to track the spread of disease, and particularly where people are staying home versus where they aren't, just based on the GPS in their phone, which you can use to identify sort of movement. And then there's been a lot of ongoing conversations, the paper from Science that came out early that looked at using sort of this digital contact tracing for being able to identify proximity of people to others who may have been exposed. And so it's really complicated, and I'm sure many of you are thinking, wow, it's sort of interesting that this data can potentially be used for tracking and understanding sort of disease. but also it raises these important ethical and regulatory questions related to how this data is used. And so when you buy a smart thermometer, you probably aren't thinking that this might be used to end up on a map for people to track whether or not you have symptoms or not. When you're using your phone and you're traveling throughout a city, you're not thinking that that information is being mined to track and identify where you are, and particularly potentially link you with a disease or an outbreak or not. And so there are several examples that have emerged relative to this data, which certainly would give us pause and that are really important for considering how we might incorporate this data into our clinical practice, into research, and into policy. So, a few years ago, there was a lot of information that emerged about Cambridge Analytica. And so what happened there was a group of researchers basically consented people to have access to their Facebook data. And they then had them take a series of personality tests. And then they were able to then use that to make inferences about not just the person who had consented, but all of the people in their network. And so if you initially started with several hundred people, you can now have information on hundreds of thousands of people once you access their network and made assumptions about what their personality was relative to others. And there's a lot of negative press about this because this was considered to be sort of misuse of the data and misuse of sort of the network, because one person consented, but not necessarily other people. And this information can be used to potentially sway people's decisions about election or provide them with information that could then give you really good clues about the ways, the choices that they may make. I'll give another example from OkCupid, and you don't need to say in the chat if you use OkCupid or not, but it's a popular dating site where if you're familiar, the way that it works is that you fill out a survey of all the sorts of things that you like and what you're looking for in a partner. And so you like long walks on the beach, you like eating hoagies, you like going to the High Line, you like lots of different things. And so then they see what another person says, and then they match you based on how likely your profiles matched. And so what they did for this study was they said, we're gonna pair people with the person who is the exact opposite. So this person can't stand going to the beach. They don't like the sand. They're allergic to horses. They don't like the High Line. They, hoagies are their least favorite food, and they're different religions. They come from different backgrounds, and they like completely different things. And they said, this is the perfect match for you. This is the person you absolutely have to go out on a date with. And so what they did is they were able to, through the algorithm from this computer, get people to go on several different dates with somebody who they knew had very opposing views, likes, etc. And so this again was identified as an area of manipulation because it demonstrated the power of these platforms to impact how you vote and even who you'll go on a date with. And so you'll see that there is a lot of power in how you can use these potential platforms for changing behavior. Another example is Facebook with emotional contagion. And so this was a study that was done where they changed the valence of the information that was in your news feed on social media. So here they said, we're going to show you things that are slightly more positive. And so you're scrolling through and the news feed, it feels pretty random, right? It feels like just information that's sort of appearing in your news feed. But here they really curated it. And they changed the valence slightly to show that information that was slightly more positive and for another group that was slightly more negative. And what they were able to show is that by changing the sentiment of the information that you saw, they were able to then make people post in a way that was slightly more positive or slightly more negative. And so you can see here across these examples that, there's the potential of, changing behavior, how you vote, which is a pretty big deal, changing who you go out with, who you spend, as residents, in fact, that little bit of time that you have, that little bit of free time, like they're gonna impact who you will actually go out on a date with. And then, in just the passive scrolling, these platforms can be used to change sort of your mood and if you're feeling positive or negative. And if you can change somebody's mood, you could then change other things that might impact how they'll make other choices. And so these are just a few examples. And if you want to put some other examples in the chat, you might want to do that, of ways in which we should think about the trade-offs between how we use these platforms, the information they provide, and the ways in which they can be used for misuse, manipulation, or contagion. And so our work has really focused on, well, how do we in this context responsibly mine and ethically study these digital footprints that would support a culture of health and inform healthcare delivery? So I'll take a pause there before sort of going on to some of the ways that we've started to do that, if anyone has any questions. So I'll keep going here. So we have been thinking specifically about that, and we've established over the past couple of years a infrastructure for individuals to be able to donate data. And so here we're asking people to donate sort of all of their social media and other digital data sources, as well as donate access to their health records. And then we would combine this information in a shared sort of research database that could be used for trying to identify different things that allow us to predict more about health. And you can imagine that if you could have this access to this information, it might allow you to have a better understanding of your patient's health, their healthcare utilization, based on just the digital footprints. And so we've been very, very focused on making sure that we are attentive to these issues related to ethics and privacy, and that we completely protect this information in the same way that we would protect health record information. And so while not required by the IRB, we put in specific protections in place that make sure that the information that people share is as guarded as their health record, because it's our belief that embedded in all of your digital data are a lot of clues about your sort of behaviors, the future choices that you will make, the decisions that you will have, and the things that impact how you think about the world and the choices that you make. And we think that that's really valuable, and that in trying to unlock that data, we need to make sure that we protect it. And so we have specific things in place for privacy, for informed consent, and for allowing people to at any moment unshare and decide they don't want us to have access to that data. And so we've put a lot of protections in place. And somebody asked, what was the outcome of pairing opposites on those dates? Aha, so I'm glad you asked that. So what they found is that they were able to get people to go on up to 3 dates with people who they were paired as opposites. And some of those even went on more dates, which suggests maybe there's something, you know, problematic with the algorithm, but also that they can pair people and get them to actually, the example is about being able to influence the choices that we make. So I'm not sure in the audience how many are residents versus sort of faculty, but for residents, like, you don't have a lot of time. Like 3 dates is a lot of time that, you know, you could potentially, you know, be spending otherwise. So I think it's a powerful example for saying how these platforms can influence how you spend your time. So thank you for that question, Frederick. And so we specifically put in place lots of protections for this data. And what we found is that when we had asked people in emergency departments and internal medicine clinics and in the postpartum suite and in our memory center, so across 4 different locations, we asked people to share access to this data. And of people who had access to social media and who were willing to participate in research, we found that approximately 86% of those have been willing to share access to these data sources. And to date, that represents more than 6,000 people who have shared access to both their social media data sources as well as their medical records. And we have been hyper-focused throughout this entire process on making sure that we protect this data and are really rigorous about the ways in which we protect the information. And our focus has been on first identifying feasibility and acceptability, things that would be interpretable and actionable, and relevant and highly applied, and able to advance science and patient care. It's very easy to have a large, massive data set. Sometimes this represents sort of billions of data points. And you could go fishing and say like, oh, I want to know if there's an association between this and this, or I'm wondering what people with this condition say about this. But we've tried to be very sort of focused in A, being respectful for the data that people shared, and B, trying to make sure that we focus on asking scientific questions that we think might advance patient care. And so I'll give a few examples. One, mental health. So I think people, would think that people do share a lot about their mood and their feelings. And so here, this is a paper in PNAS that I did with a computer scientist and a medical student at the time who's now a pediatric dermatology resident. And we looked at, could we predict depression in the medical records in the 3 or 6 months before the first diagnosis in the medical records, just based on the changes in individuals' language on Facebook. And so here we showed that we could predict there were difference in those that had depression and those that didn't have depression, just based on changes in their language before that diagnosis in the medical record. And then when we looked at people, what people talked about, they were more likely to talk about their depressed mood and feelings, about feelings of loneliness, hostility, somatic complaints, and then lots of references to medical references. And then moving on to diet and lifestyle, which I think will be pretty relevant for this audience. You can imagine that you ask patients, you want to do some sort of counseling around nutrition. You say, oh, tell me about the types of things that you eat. Tell me a little bit more about your potential exposures. And that, I can recall maybe what I ate up till yesterday. If you really push me, I might recall what I had over the weekend. But it's really hard to have an understanding sort of all of the dietary choices that we make and the things that we eat. And so here we looked at about 50,000 different images, and these are actual images, which is why they don't look like pictures from the internet. But these are rather actual images, and they're de-identified, where we looked at the types of things that people were posting. And you can imagine that what you post on Instagram might be a little bit different than what you're eating on a day-to-day basis, because you want the pictures that you put out there for the world to see to be a little bit curated and to really sort of reflect things probably that look appealing or that have a certain something associated with them that make them more likely for people to want to eat. To see them. And so we found that about a quarter of the images were just what people were drinking. So you can see on the top right or patient left image, the two sort of Dunkin' Donuts culottes with whipped cream and chocolate sprinkles on top, that, a lot of people are consuming a lot of calories through the things that they drink. And then there are lots of images that people have of alcohol. And you can see the picture below with all of the shots. Some of the pictures are lots of fruit. A lot of pictures are, I think that's like a calzone with 2 liters of Pepsi. And then some that reflect sort of pictures that are from what people get in schools. And what we found is that about 7% were pictures of people eating in their bed alone. And so a lot of people were sitting, there's a picture, you see their tray of the food, the television in the back, and they're sitting in the bed. And so you're seeing that, context can really matter. And so there are things that we can learn from the ways that people share about their eating environments that we could use for counseling or providing more specific information that might go beyond sort of people saying, I'm eating healthy, doc, I have baked chicken and salads. But when you really see what's on the salad, or you really understand the volume of the baked chicken, or you see that it's paired with the double Dunkin' Donuts culotta with the whipped cream and sprinkles, then that gives us sort of different context to the types of things that people are eating. We looked again at chronic health conditions, and here we were thinking in terms of sort of the genome and sort of different SNPs that you might see. So we looked across the language of several millions of posts of individuals who had the chronic conditions that were listed, or conditions that are listed on the left. And we could identify and distinguish diseases and conditions just based on language. And here we looked at the similarities and the differences across and how people with certain conditions share certain language across these conditions. And we could identify or predict, I think 75% of these conditions just based on differences in language. And then we looked at pregnancy, because I mentioned that we recruited in the postpartum suite. So we recruited patients who are in the 1 to 2 days after delivery. So they weren't considered pregnant patients because they had just delivered. And so we recruited those patients. And again, around 86% were willing to share access to this data. And we were able to predict, just based on the language that people use, differences in time points in pregnancy. So before pregnancy, people use words about being bored, that were chilling, they were at their house, they were going out, they were listening to music, and they were cursing a lot. And then during pregnancy, there might be more words that you might predict around family. They were hungry, a lot of focus on dates, and talked about being in hospitals. Then after pregnancy, there's a lot around gratitude. They talked about the appointments, a lot of focus on religiosity. And then we could even distinguish by trimester, so differences in language between first, second, and third trimester. And the application here would be for being able to identify people pre-pregnancy or during pregnancy, early pregnancy, to make sure that we're providing information that can make a difference in maternal health that's early on, or targeting messages to those that are in their third trimester. So we have the sensitivity to be able to see differences between time periods. We've also looked a lot at healthcare utilization. And so here, we looked at being able to predict differences in language before an emergency department visit or before an inpatient visit. And so the inpatient visit, the AUC was 0.7, the emergency visit more likely due to chance, but for predicting people that was of language, people identified based on their proximity to being admitted. And we've extended this to looking at Google searches as well. And so I think of your social media data as something that you want kind of the world to see, something that people are, you curate it to an extent before you post it. But what you search for on Google is more so between you and Google, right? So it's what you're looking for that might reflect kind of your questions, your fears, your concerns, your perceptions. And it isn't public facing. And so I think that people will reveal or post things differently in that setting than they will relative to things that they may intentionally put on a Facebook page. And so for 2 different studies where we looked at patients in the emergency department, and we asked them to share access to all of their Google search data, and again, their health record data. And we protected this in a similar way because we think your Google search data is really something that we wanted to protect in the same way that we would information that would have PHI. And we were able to identify about 60% of people who said they use Google and were willing to participate in research shared access to all of their Google search data. And this is their retrospective data. And so in that context, we were able to identify differences in the searches right before an emergency department visit relative to searches that happened at other time points. And then also this is work that I did with a pediatric fellow who is now an oncology fellow. Oh, he just finished. He's actually now his first year of being in attendance. And so he was interested in, for individuals who've just had a diagnosis of cancer, what are the things that we aren't addressing in that visit that we sort of miss? And so here he asked parents of kids who'd just been diagnosed with cancer to share access to their search data. And he again had about 60% of parents who said yes. And then he looked retrospectively at what they were searching for before their child was diagnosed, then once they get the diagnosis, and then because he consented them several months later, sort of what sort of things were they still searching for after visits. He was able to identify several things that emerged that they're now looking at trying to be sure to include early on, or references or links for, just because they found that there were things that people were searching for that they could get more target at and being able to provide information to. Inevitably, after sort of a diagnosis. People will go online to look for things, but how can we make sure that we're giving people access to accurate information and trying to address those things that would be important? And then we've looked across sharing lots of different data sources. So I started in the beginning with the graphic from the JAMA article, looking at these both structured and unstructured data sources. So here, we asked a different set of patients about their willingness to share access to different data sources. So I remember, I think Ava said the Apple Watch and the Fitbit. And so here we asked for a whole range of data sources. And we said, would you be willing to, this is a deception study where you ask people, would you be willing to share this data? On the next screen, we're going to sort of access this data, and you'll need to log in to provide access. And so to try to model what would actually be their choices. And then what happens is when you click off the ones you would share, when you get to the next screen, we say, actually, we're not going to ask you to share this data. So we're able to capture sort of their intention here. And so here you can find many people are willing to share their Spotify or their Pandora or their music streaming. Many people are willing to share their voting data, their genetic data, access to all of their email, their GPS data, fewer their Snapchat, and 9% were even willing to share access to all their credit card data. And then the orange bars, you'll see, reflect their patients' willingness to share data sort of after death. And the idea is that people may have a sense that their current data actually, they wouldn't want other people to necessarily know about or to mine it, but that they might, I bequeath all of my data to Mount Sinai at my death for them to use to potentially unlock clues to particular scientific conditions, and that my data may, in fact, in the same way that my genetic data may be helpful, my scientific data, my digital data may also be helpful. And so this is what we were trying to model here. And we can see that people were much more willing to share their data sort of after death. And we've been working on trying to think about ways of modeling for patients to be able to share data, which we think really might be meaningful in our understanding of certain health conditions. This is some work by Charlene Wong, who was a fellow with us, pediatrician who's now at Duke, where she talked about in JAMA about giving data back to patients, because I think that this is critically important. It's important for us to mine and understand for us to understand what our data reveals about our health, but also we should think about really critically about how do we give data back to patients. And so what data should be returned, when, and how should we do it were some of those important questions that she raised. We've done a little bit of this work through these social media snapshots where we've given people access to their data in terms of when they're posting, what they're posting. We've correlated that with their stress levels and also given them tips and other information. And the tips people found most helpful, even though they were somewhat generic, about the types of things that we were identifying from their data. And at present, we're now looking at, we have a large RCT, which is planned to start, where we're going to give people access to their digital dashboard in the course of mental health therapy, that particularly now in the era of telehealth might give them more information when you don't have those in-person cues about how people are doing in their mental health. We have a large study ongoing that is looking at digital phenotyping to predict cardiovascular risk. So looking at the added predictive ability of your information on online sources and how that can provide insights about your heart disease and your long-term cardiovascular risk. And then we're doing ongoing work where we're phenotyping to identify and treat loneliness. We have a cohort who we had been tracking to measure loneliness pre-pandemic, during the pandemic, and then after the pandemic. And we're looking at digital phenotype markers throughout that entire course. And so what I've talked about so far really focuses on individual sort of digital phenotype data that is collected, produced, and generated by individuals. And I'm going to transition to talking about data that is more at the level of the facility or the hospital facility and move away from the individual. But I want to pause for a moment for any questions or things that people want to put into the chat before I talk about online platforms and healthcare delivery. So I'll keep moving, but I'll make sure that we have lots of time for questions. at the end. And if there are things that come up, I have the chat open on the other screen, so I can pause to look there. So now I'm going to talk about online platforms and healthcare delivery. And this is some work that I did with two internists, Kevin Volpe and David Ash at Penn, where we wrote about our ability to learn by listening through improving healthcare in the era of Yelp. And so I think we traditionally think about Yelp for rating restaurants, if we still go to restaurants and eat outside, or businesses, if we still go into certain businesses. But there was a time, so, bear with me here. Remember when you used to go, and sit outside at restaurants, and then you would write a Yelp review, or you would go inside a place and reminiscing, and you'd go inside a place and you'd shop and you'd get some things. Well, you remember those days. So, and then many times you would write a Yelp review about your experience. You would go to a hotel. Remember hotels? You would go to a hotel and you might sort of write a review about your hotel or that great trip that you took. And so in the same context, people go to hospitals and they go to healthcare facilities and they write reviews about them. And often they write really long and passionate reviews about them. And I think we traditionally think of these as you write things when you have sort of a polarizing experience, either really positive or really negative. But there are a lot of 2s, 3s, and 4s in between that people write about. And patients are incredibly insightful about the things that they can write about and share. And particularly, Yelp is democratizing in that it allows sort of family members to write. You can recognize that the family member is often the person who is sitting at the bedside day in and day out and experiencing the hospital and healthcare in a different way. And we don't ever systematically study or ask these people about their experience. And again, I guess that's when people used to be able to have lots of visitors in the room, which now that has changed as well. But that's an important segment of the population that can provide insights about how we can improve the experience of healthcare for both individuals and patients. This is sort of the anatomy of an online review, and I picked HUP. I could have very easily have picked Sinai, but this sort of shows that you get the facility name, the star ratings, the number of reviews. Sometimes you get an image of the person who wrote the review, and then there's some other information about the business as well as some images. When you look at the actual content of the review, you get more information about the reviewer as well as the review text and some of the engagement. And so as with the other work, we do a lot of machine learning and natural language processing to analyze data that would happen over hundreds of thousands of reviews with millions of words that you can use to identify through automated processes differences in what people are talking about and identify themes. A picture is worth 1,000 words, and so people also post lots of pictures of their hospital experiences. This is what a room looks like. Some of the resources, here's some advanced charging. This room is clean. Here's a sign that made it a 6-star. Very personal things like pictures of your kid's ultrasound, pictures with your cat, proof that you were there, so picture with the armband that you can see, and then pictures of family members. So people include a lot of information in these reviews. They're written by patients, family, friends, providers, and then others. You can't validate like who the person was, except maybe if they have their armband in the picture with their name and their medical record number. And we've been working really closely with Yelp and looking at healthcare facilities to understand more about patient experience through these online reviews. To date, there are more than 500,000 healthcare facilities and more than 4 million reviews that we've been analyzing. We've looked at hospitals, emergency departments, urgent care, substance use disorder, mental health treatment facilities, and nursing homes. Of note, in many of these facilities, there are no standardized reporting measures for the patient experience. So for substance use disorder treatment facilities, these individuals don't get a survey like HCAHPS or Press Ganey after you're in a treatment facility about how your experience was. And so we found that these online reviews provide some different context about the experience that we otherwise wouldn't be able to access because we don't have a validated, standardized way of collecting these. So I did some work with Ben Renard, who just finished his internal medicine residency at Duke and is now a critical care fellow at Columbia. And we did this work looking at comparing hospital reviews with HCAHPS. And we were able to identify that the Yelp reviews cover the majority of the domains of HCAHPS. And then there were an additional 12 that people talked about as being important that aren't captured through HCAHPS. And the majority of the things that were the Yelp topics that most strongly correlated with positive or negative reviews were things that we don't measure or report by HCAHPS. And so this suggests that there is another sort of type of information, particularly around patient experience, that we can capture through these online reviews that people write about healthcare facilities. This is some work that I did with, he was a fellow at the time, but is now faculty member, where we looked at the word that was most used in negative reviews of healthcare facilities. And this was in Journal of General Internal Medicine. And the word that was most used was told. And so again, we looked at hundreds of thousands of reviews of hospitals. And then we looked at the words that were most associated with 1-star versus 5-star reviews. And the most statistically significant sort of words are the ones that appear in this word cloud. And the largest one here is told, representing the word that is most commonly appears in the negative reviews. And to me, that doesn't suggest sort of shared decision making. It's not just, you know, word bad, I see rude there and waiting and billing, but really it speaks to communication. And I was told this, they told me that. It wasn't, we had a discussion, they shared this information, they told me this. Speaks to some of the hierarchical sort of conversations that we have in medicine, but just sort of this lack of, you know, sort of shared conversations or ways in which we're communicating. And so this was sort of illuminating to us and thinking about how we have conversations and how we share information and how we engage in dialogues. We've also looked at, here our CEO of the hospital was interested in understanding more about differences between emergency department care and urgent care. And so here in the urgent care side, there are no sort of standardized reporting measures for how we collect information from people after they've had an urgent care visit. And so here we compared and looked at differences in the types of things that mattered most to patients when they were having care at an urgent care versus in an emergency department. We've also looked at substance use disorder treatment facilities, and this was published in JGEM, where we looked at differences in both Google, primarily Google reviews and ratings of substance use disorder treatment facilities to identify sort of what types of things people were most posting about and variability in the types of ratings. And here we were able to get 92% of all substance use disorder treatment facilities in one state had some Google review or rating associated with them. And then we were able to correlate those reviews with the types of services that were offered. And here you can see that the distribution of ratings is between 1 and 5-star, and that you would anticipate that most of the reviews that people would write would be when you're angry or pretty fired up, and that they would be negative reviews, but here there were more positive reviews than the negative reviews about substance use disorder treatment facilities. And then this is some work I did with Kira Raskina, who is an internal medicine faculty member at Penn, and this just came out in JAMA Network Open a few months ago, where she looked at nursing homes and nursing home online reviews compared with rehospitalization rates. And here we identified that facilities with the highest rating on 2 review websites had 2% lower rehospitalization rates compared with those with the lowest ratings, meaning that we can use these reviews and that several point differences can allow us to predict rehospitalization rates, and that there was a lot of the content that people talked about that we could use to better understand what mattered most to patients and their family members at these nursing homes. So overall, my view here, and these are just my summary of studying digital health and platforms for a while, is that they're going to inform the advancement of of science and public health, and that the future of medicine is going to require our ability to integrate these new data sources for how we manage health and how we deliver healthcare. And some of that will be in the form of social media and other external facing platforms where people are now connecting information that in the past would have just happened through word of mouth. And then others will happen through our use of these platforms and how we text and communicate with patients in other ways that happen through digital means that in the past would have happened just on the phone or in person. And that this sort of collection of digital data and sources and platforms is all going to sort of be very much at the forefront and a part of how we practice medicine and how we communicate and understand and better listen to our patients. So I want to thank you for your time, for letting me be the first external speaker. And I know that it's so much more impersonal to do this online. So I appreciate the comments in the chat. And then I want to pause here for any comments, questions, or reflections.
Great. Thank you, Dr. Merchant. So looking forward to questions and comments coming in the chat. I was thinking, Dr. Merchant, when you were talking, as we wait for the chat to come in, and this seems like an extremely powerful tool to look at health disparities in healthcare, and I'm curious if you could sort of enlighten us a bit on how you're thinking around that.
Yeah, that's an excellent question, and I'm glad that you brought that up. I only sort of briefly mentioned kind of this the current pandemics that we're facing right now related to both COVID, which I primarily focused on in the beginning, and then thinking about disparities, racism, issues of equity, inclusion, and I'm putting all of those words in one bucket, recognizing that they represent different things. But I think that there are sort of two things that are important here. One is in thinking about how, while the digital divide is being narrowed, and that more people have access to social media, it's pretty democratizing that way, and that these sites are free to use. And so we know that for some demographics, they're disproportionately use sort of social media more than others. Well, the digital divide is narrowing in terms of how people use them. The access to the actual technology, however, there are still sort of huge barriers in that, and this has particularly come to bear in the era of COVID, and particularly around schools and access to digital devices. But that while people have access to the platforms, they don't all have access to the same sort of devices. So I think that's one really important part that you highlighted. I also think that we can understand different populations through the language and the ways in which they post and use these platforms that can give us more insights into how we can provide more responsive and more personalized care. And so in understanding people's environment and the particular things that they post about in their exposure, we might be able to provide more personalized care that would address kind of their specific sort of environment and circumstances. And so I think that we're learning a lot about both the disparities that happen just through looking through the lens of the patients. I also think, and then a third place is being able to understand more about the disparities and the experiences that people are having and the ways in which they post and share. And so that's some of the work that we're doing right now, is in trying to understand sort of how are ways that we as healthcare providers can be more responsive to the experiences that people are having that represent sort of disparities in access and care and treatment and their perceptions. And so I think we're going to hear more about that. And now that this topic is at the forefront, we'll hear more about how people are thinking about better listening through these tools to understanding. And I think the institutions that will be leaders here are the ones that find ways of better listening and then being responsive to changing these very subtle things about sort of patient experiences. But it's such an important question, so I'm glad that you brought that up. Yeah. I see another comment from Fred. Do you want to unmute and ask your question?
I'm not sure he can unmute on the way.
Oh, okay.
Yeah.
So Fred asks, would big pharma and medical technology firms be interested in whether I like hoagies from the Italian market? What's the firewall between your research and the medical pharma healthcare complex? So I think that that's an interesting question. The information that people post online publicly is available for anyone to access publicly. I think what's different about some of the work that we've done is that we've taken some of the guesswork and the assumptions out of, if I solve Frederick Sherman and I looked at your profile and you like hoagies, you like the Italian market, you like lots of different things, I might make certain inferences about the choices, and then I might use that to market different products to you. What we've done is pair that information with your health record to see that the number of your hoagies is associated with your cardiovascular risk in ways that we might not have been able to tell without that direct linkage. And what we're trying to understand is sort of the sensitivity of the data and how well we can use that to actually make these predictions. What the other sort of people looking at this publicly won't have is sort of how it links to your risk. Now they might then see that you went and started searching for statins and side effects of statins and where to find a primary care doctor and other things that you could use to piece together to show that your hoagie use was tied with your cardiovascular risk, with your starting a statin, with your needing a cath, with your, and all these other things that could be identified from your footprint. But we would have this more validated set of your actual health record data that would allow us to make these connections between your actions online and your actual use of healthcare.
Other questions and comments?
I guess I'll say while waiting for other questions that Masha, what I've talked about, I tried to highlight work that was both interdisciplinary. This work happens a lot with computer scientists, but really, although I'm an emergency medicine physician, I've done a lot of this work with internal medicine physicians, and that a lot of the work has been published in journals that are pretty general. And I think that this is an interesting area because it is still so new and thinking about the potential applications. I think the privacy and the security are just like critically important in thinking about how we conceptualize and how we do this work in a way that is really informed by patient preferences and really responsive to the needs of our patients. And so I direct the National Clinician Scholars Program, where we train young physicians and thinking about more broadly health services research, but in thinking about sort of the breadth of ways in which we can scientifically study these and other areas. So I would strongly encourage any of the residents, if you're considering for thinking about pursuing broader health services research through fellowship.
That's great. Anyone have thinking of any other comments? As a person from Philly, it was nice to hear the word hoagie put into a grand round so much today. For those of you who don't know, a hoagie is a sub up here in New York. So that was terrific. Dr. Merchant, it was an absolutely excellent talk. I know everyone enjoyed it. I did very much. And I want to thank you for coming on, and thank Derek Bresman for introducing you to us, and looking forward to one day shaking your hand and thanking you for an excellent lecture. So thanks a lot, appreciate it, and have a nice day, everybody. Thanks.
Thanks so much.
Yeah, thanks, Dr. Merchant.